Treatment approach. Treatment decisions for adolescent idiopathic scoliosis (ICE) are based on the initial deformity at presentation and rate of curve progression, as well as an overall assessment of the patient's growth potential. The main goal of treatment is to prevent progression of the spinal deformity until the patient reaches skeletal maturity. Once the patient has reached skeletal maturity, the risk of curve progression decreases significantly. Treatment options for ICE include observational monitoring, bracing, or surgical spinal arthrodesis fusion. The selection of treatment is based on the severity of the curve and the amount of growth remaining until skeletal maturity. Screening scoliometer measurement less than 5 degrees or standing coronal Cobb angle measurement is less than or equal to 10 degrees. These measurements allow a diagnosis of postural deformity to be made. No treatment or observational monitoring is necessary unless the patient or family identify worsening postural asymmetry or the patient develops symptoms to suggest the presence of another underlying cause for the spinal deformity. The patient should be advised to maintain a regular fitness routine, specifically toward developing improved core strength and conditioning. Standing coronal Cobb angle measurement of 11 degrees to 20 degrees. Observational monitoring with follow-up standing PA and lateral scoliosis X-rays at 4 to 12-month intervals depending on the estimated rate of growth and remaining growth potential at the time of evaluation should be undertaken. The patient should be advised to maintain a regular fitness routine, specifically toward developing improved core strength and conditioning. Standing coronal Cobb angle measurement of 21 degrees to 45 degrees. Brace treatment has traditionally been used in patients with a curve of greater than 21 degrees. Many brace options are available, and the specific type of orthotic used varies between surgeons and from country to country. Braces commonly used in the U.S. are the Boston and Rosenberger braces and the Charleston bending brace. Several brace-wearing schedules have also been proposed, ranging from 23 hours per day to nighttime-only bracing. While some studies have supported a dose-dependent relationship between brace wearing and curve progression, it is still unclear which brace-wearing schedule provides the most reliable outcome. The Scoliosis Research Society consensus supports the use of an 18-hour-per-day bracing schedule. Scoliosis Research Society other organizations have also attempted to develop consensus of care statements and guidelines in an effort to standardize scoliosis brace treatment protocols. The goal of brace therapy is to prevent curve progression until skeletal maturity, at which time the risk of further curve progression significantly reduces. Data from the Bracing in Adolescent Idiopathic Scoliosis trial have shown a significantly lower risk of curve progression in patients with ICE who wore a brace compared with those who did not. A Cochrane review concluded that all of the included studies consistently showed that bracing in ICE prevented curve progression, including 7 separate studies that included a total of 662 participants. The patient should be advised to maintain a regular fitness routine, specifically toward developing improved core strength and conditioning. Standing coronal Cobb angle measurement of greater than 45 degrees. Due to risk of further curve progression and associated morbidity as an adult, the treatment recommended for this group of patients is to proceed with surgical spinal arthrodesis. Spinal arthrodesis with instrumentation serves several treatment objectives, including achievement of maximal deformity correction, improvement in appearance with trunk balancing, cessation of continued curve progression, and reduction of both short and long-term complications related to the spinal deformity. The choice of surgical approach and instrumentation technique is dictated by the characteristics of the deformity, e.g., location of the curve apex, degree of spinal flexibility, and surgeon preference. Most deformities can be addressed with a posterior approach that has traditionally been the optimal technique for surgical arthrodesis of the scoliotic spine. Some surgeons use an anterior approach with the belief that the deformity can be corrected with a lower number of fused levels. However, this approach has a higher incidence of implant failure and pseudoarthrosis compared with the posterior approach, and has been associated with a risk of pulmonary complications secondary to the need for single-lung anesthesia during the procedure. The patient should be advised to maintain a regular fitness routine, specifically toward developing improved core strength and conditioning. Please subscribe to my channel. Thanks for watching. You can consult with me by clicking on the links indicated under the video.